Thank you so much, Thais, for the wonderful transition from the Danish forest to the rainforest. So I'll talk now a little bit. Let's see. So the talk I'm going to do now with that wonderful introduction really does try to at least start on illustrating how the roadmap can be applied sort of outside some of the more basic questions with classic randomized control trials. So we really, I think, saw yesterday or even the past 2 days that even what seems like a simple question like the benefit or harm of a new agent in a well-conducted RCT already opens all sorts of questions and a need for a roadmap so we get as close to our destination as possible and don't miss key opportunities to do a better job learning from our data. So with this talk today, then, I'm going to move a little bit beyond that in some ways, one of the easier questions, even though it still raises complications, to some more complex data settings. And to do that, I'm going to use a running case example from my work looking at HIV and really better ways to deliver treatments that we know work, better ways to get them to the people who need them. So this is much more in the space of observational data, global health, and really implementation science. How do we deliver evidence-based interventions better? That said, I think it has, all of these questions have very close analogies to the pharma industry, as Henrik really outlined in the first day. I thought that was the perfect framing. That if it's a challenge we face in complex observational data in global health, it's almost always a challenge that's also faced as we try to learn more from both randomized control trials, registry data, and other data sources about the effectiveness of new agents and how they work. That said, it's always a bit more interesting to hear about a case study with just a teeny bit of motivation. So this slide is just to say that we are in the midst of one pandemic, clearly, but the HIV pandemic remains, and it continues to really exact high human tolls across the globe with a disproportionate burden in sub-Saharan Africa. This is the WHO map of HIV prevalence. They've done it by continent, but this also obviously masks huge heterogeneity within continents. Also in sub-Saharan Africa, where I work and where the burden of disease is so high, there really are limited financial and human resources to address the epidemic, which means making the best use of the ones we have really important. My second background slide to just frame our case study is to point out that even among persons that start that link to HIV care and start treatment, drop out of care remains very common. Occurs for all sorts of reasons, structural, logistical. There are a number of barriers to care that can arise, but this is really an important problem because when colleagues have done work tracking people or sending out folks on motorcycles to see what's happened to people who didn't come back to care, the mortality rates are extremely high. So that brings me to what I will use as a running case study in this talk. So this is an example looking at the effect of nurse-based triage, so triage of care for patients who are clinically stable from doctors to nurses, and how that impacts whether or not patients with HIV are able to stay in HIV care. So we're going to use this first to just review the causal roadmap for a point treatment effect. And you may have thought you've heard enough about that by now, but I think it's worth doing because it really lets us build the ingredients for the longitudinal questions that we want to ask. And so then next I'll extend that point treatment roadmap really to this case where we're interested in the impact of multiple treatment decisions over time, and there's also informative loss to follow up. So talk a little bit about implementation choices and show some data and simulation results. Again, I'll say this example is drawn from HIV, but the analog in both observational data and RCT settings for looking at pharmaceutical agents, it includes all those questions we heard about from Henrik on the first day, about, also from me, about what happens in a trial if you want to ask, well, what if I had been able to prevent anyone from changing therapy and somehow intervened on dropouts and also prevent switches, for example. So all of those questions about ideal regimes that involve decisions after somebody starts a randomized treatment are exactly applicable to this longitudinal roadmap I'll talk about today. So here was the question. This was an example where I wanted to use observational data to understand the impact of a program called Low Risk Express Care. So what's low risk express care? Again, it's this idea that clinically stable patients or low risk patients could have their care shifted to nurses, and that by doing that, it could be good for everybody involved. So it could free up doctor time to allow them to spend more time with sicker patients, and it could really make sure that lower risk patients may get even better care from the nurses, again, because people have the resources and time to spend with them. And so this was implemented in Kenya in 15 clinics in 2007 to 2008 as part of a USAID AMPATH partnership. And just want to thank IDEA East Africa cohorts for this collaboration. So with these data, then the question was, what was the impact on a patient of being enrolled into this program on loss to follow-up and death? So here we're considering a composite outcome that reflects both whether a patient drops out of care, whether they die, really treating that as a sort of a joint failure. So it was really unknown going into this. Was this beneficial? Was it harmful? The hope was that it did save resources, so at least it wasn't harmful, but maybe it was even beneficial. So the data available to evaluate this were really observational clinical cohort data, or pulled from these 15 different clinics. And in these data, there were a number of low-risk patients that met these eligibility criteria, and they enrolled at different times following that eligibility, where at each time point, whether or not they enrolled was not random. It was at the discretion of themselves and the providers. So with that motivation, that brings us to our familiar causal roadmap that we've seen so much of. So we'll now just step through what that looks like first for a simplified version of the question, and then use that to build out the more complex version of the question. So just to remind folks, here are the steps that we'll step through. So we're going to first specify our causal question. And here we're going to do that using the concept of counterfactual outcomes and ideal interventions or ideal experiments. Second, we'll specify our observed data and our statistical model. Again, remembering that we're really using statistical model to mean the set of possible observed data distributions. And we're going to be working in models that are big enough so that we know they contain the truth. We'll have our step of causal identification. So this process of translating that causal question into a parameter of the observed data distribution, or a statistical target parameter, and be really clear about what the causal assumptions are. And then finally discuss estimation. So here we've heard a lot about the targeted maximum likelihood estimator in this webinar. I'm also going to briefly introduce today two other estimators that I suspect are familiar to many people in this webinar: the IPTW estimator, or inverse probability of treatment weighted estimator, and the parametric G computation estimator, which relies on typically parametric outcome regressions. So I'll do that because I think it's interesting to contrast the properties, and also by spending a little time with those estimators, we can understand how they feed into the targeted maximum likelihood estimator. So in our example, we're going to start by defining a time scale. So first, our baseline time point here is the time at which patients first become eligible for this program. So that's when we start the clock in our ideal experiment. For time scale, we're going to work with a 90-day discrete time scale, and that reflects really the frequency with which patients are seen in clinic, at least at that point, at least historically. If they don't drop out. Our intervention to start with is just going to be a single time point, single decision intervention. So we have this group of patients, they're eligible for the program, we start the clock, and then our intervention is just either they enroll immediately or they don't enroll immediately. So a single binary intervention at a single time point. And so with that defined, we can think of our kind of simple counterfactual outcomes. So we'll talk about counterfactual outcome under treatment or under the intervention as Y1, reflecting a person's counterfactual retention status 18 months after baseline if they had enrolled in the program immediately. And Y0 will be their counterfactual retention status at 18 months if they had deferred enrollment. So just like we've done over the past 2 days, we can then use this to define a target causal parameter. So for example, the counterfactual probability of remaining in care and alive at, or I'm sorry, flipping it around to say counterfactual probability of having been lost to care or died by 18 months if you had been enrolled immediately in the program versus you had not been enrolled immediately in the program. So moving forward then, we'll just focus on the expected counterfactual outcome under some value of the intervention, recognizing this can apply to both A is 1 and A is 0, or treatment and control. So our observed data for this problem were about 15,000 copies of, to start with, we'll discuss a simplified version of the observed data. So of baseline covariates. So this included age, sex, CD4 count, et cetera. Treatment, so this binary indicator of whether they enrolled immediately in the program, and then an outcome, whether they were lost to care at 18 months. We have a statistical model, whereas we've been emphasizing we want it to reflect our real knowledge. And so if we think about factorizing the observed data distribution into the distribution of the baseline covariates, the distribution of the treatment given baseline covariates, the distribution of the outcome given treatment and baseline covariates, we're going to be working with a model that places restrictions, if any, only on this treatment mechanism or propensity score. So that brings us to our identification step. So formally, we've seen these assumptions nicely presented yesterday by David and Helene. Here they are for this simple single time point case. We need really 2 fundamental assumptions. One is, and they can be stated in terms of the causal graph, but also in terms of the counterfactual outcome. So the first assumption is this so-called randomization assumption, also known as many names. Conditional exchangeability is another frequent description. So what does this say? It says that the counterfactual outcome is independent of the observed treatment given the baseline covariates. So in other words, the baseline covariates we measure are informally sufficient to control for confounding. Now, this can be, while a nice formal statement, it can be challenging to evaluate whether it holds. Are there reasons we think it might not hold? And really challenging to bring in expert contextual and background knowledge to evaluate it. And here's a place where I think the causal graph framework really is extremely helpful. So it turns out we can also write down a causal graph to describe what we know and what we don't know about the process that gave rise to our data. And it turns out we can use a causal graph to also evaluate this assumption. So really what we're looking for in the causal graph is that we measured enough baseline covariates to block all the so-called backdoor paths from our treatment of interest to our outcome of interest. So in this causal graph, the red line is the causal effect we care about. And due to these shared common causes, they essentially open a potential additional source of association between the exposure and the outcome, and a source of association that's not part of the causal effect we care about. And so in brief, when we use the backdoor criteria to evaluate whether we measured enough and what we should adjust for, this is really what we're asking is there some subset of baseline covariates in this case that are not affected by our exposure and allow us to block all the backdoor sources of association between our exposure and outcome. So that's our core randomization assumption, or the backdoor criteria. The second assumption is an assumption of sufficient support in our data. So basically just says that we need, for this particular causal parameter where we want to contrast the outcome under immediate enrollment and deferred enrollment, we need some positive probability of both enrolling immediately and not enrolling immediately, regardless of covariate values. So this is actually an assumption that's quite worth giving some attention to, because it can easily be violated simply by the way you frame your question. So to take a concrete example in this case, we would have a big problem here if there were people in our sample who were so sick that they just would never be enrolled in this triage program. They would never be transferred to nurse-based care. And that actually is an important piece when we're defining our target population. So that's one reason why in this first step of the roadmap, we said we're going to focus on a group of patients who are all eligible for this intervention. So if we have these assumptions, we can express our causal parameter as a statistical parameter. Where on the left-hand side, we have our causal parameter, our expected counterfactual outcome. And on the right-hand side, we have our so-called GComp estimand, a really classic statistical parameter in causal inference that just consists of an outcome regression. So the expected value of the outcome given treatment and covariates. And then integrated with respect to the marginal distribution of the covariates. And I'll say throughout in this lecture, I'm using a notation for discrete valued random variables just to simplify the presentation, but everything extends immediately to continuous valued random variables as well. So with that estimand, then we have three general classes of estimator we could think about using to implement it. These are propensity score or treatment mechanism based estimators, such as inverse probability of treatment weighting, outcome regression based estimators, such as parametric G computation, and then our double robust estimators, such as targeted maximum likelihood that we'll focus on today. So for our inverse probability of treatment weighted estimator, I think it's, again, worth reviewing this briefly or introducing it for those not familiar, just because it also is sort of gives some insight into the relative performance of the targeted maximum likelihood estimator and lets us understand some of the components that go into implementing it. So for this estimator, it's based on estimating the treatment mechanism. So in our case, the probability of enrolling immediately into the program given baseline covariates. And at least classically, this was based on parametric regression models, such as logistic regression. Now, the problem with that is that this estimator, the adjustment done by this estimator relies completely on this estimate of the treatment mechanism. And so if that's based on a misspecified parametric regression model, then the estimator is susceptible to bias. And this was a question that came up in the chat, I think, yesterday, which was, could you not estimate this with something like machine learning or super learning? The answer is Yes, but it raises challenges for statistical inference. So we could be more flexible in estimating our propensity score, and there's been some nice work illustrating that at least in a number of settings, certainly can give you a benefit, but it also does mean that we've really lost our theoretical basis for statistical inference, which is not ideal. So what does this IPTW estimator look like? Here's just its simplest form, in which basically what we do is we say, okay, everybody who followed the, who didn't follow the regime of interest, so who didn't get the treatment level we're interested in, gets a 0. And the ones who did get the treatment level we're interested in, they will get their observed outcome with times a weight, where the weight is 1 over their predicted probability of getting that treatment given their covariate. So the intuition for this really is, if you have an unusual treatment level given your observed covariates. So for example, if in our example, in general, if sicker people were less likely to enroll in the program, but you were sick and you enrolled in the program, you'd have a small predicted probability of getting what you got. And so you get upweighted, essentially to fill in for people like you who were missing. So we take these weights, multiply them by the observed outcome, and take the empirical mean, or we can also use a stabilized version of this estimator. So this estimator has also done a long and a useful service. But it does have some substantial limitations, including really being often a high variance estimator and having the susceptibility to these positivity violations or bias in the settings of strong confounding, simply because if you get a small probability in the denominator, you can get a very large weight in an erratic estimator. So next estimator, parametric G computation. So here, what we do is we focus on the other portion of the observed data distribution. So we estimate our outcome regression, and I think for many of this is actually how we learn to do causal inference, although without a roadmap, at least in my case initially. So we estimate an outcome regression, in this case, the probability you're lost to care given enrollment in your covariates. And then we could stop there, but of course we've defined our estimand as really the marginal, the G-comp estimand corresponding to the marginal treatment effect. And so to take that initial step, we take our initial estimate of this outcome regression and then use the empirical distribution to estimate the marginal distribution of W, plug both of those estimates into that G-comp estimand, and that gives us our G-computation estimator, which in practice just means grabbing each person, using their observed covariates, using our fit of the regression model to generate a predicted value, setting the treatment equal to the level we care about, so either 1 or 0, and then taking the empirical mean of those predicted values. So this also runs the risk of bias due to model misspecification. So if we do a bad job on that outcome regression, then we'll have a biased estimate. And again, while we can think about using machine learning approaches here, statistical inference becomes a problem. So that brings us to targeted maximum likelihood estimation. First, in this, an illustration for this simple treatment-specific mean in a point treatment setting. As we heard about from a number of folks yesterday, targeted maximum likelihood estimation is really a general methodology that can be applied for a whole range of parameters. And even for a single parameter, there are choices to be made. There are different targeted maximum likelihood estimators. That said, I'll just review here one common algorithm for this particular target parameter. So the basic idea, as I think everyone's heard a lot about now, is that we use an initial estimator based on machine learning, such as super learning, to generate an initial estimate of that outcome regression. And this is really allowing us to kind of bring the full power of machine learning to bear, avoiding bias due to misspecified parametric models when we get that initial outcome regression. We could stop there and just plug in the resulting estimate to the G-comp formula, but as we've discussed, we lose the basis for the theoretical basis for our statistical inference if we do that. So instead, what we do is we take that initial estimate of the outcome regression, and then we're going to update it or target it to get a new targeted outcome regression estimate. And in this targeting step, we use an estimate of our propensity score. So by doing this, we're getting the opportunity to reduce our asymptotic bias if that initial estimator is in fact not consistent. So this is really the double robust property that we've heard about, where this estimator remains consistent if either we estimate the propensity score consistently or the outcome regression consistently. But it also importantly gives us this opportunity to reduce finite sample bias and variance. So we talked a little bit about superlearning on the first day. I just will run through it very briefly here, given I'm not sure of complete overlap. In terms of what machine learning approach we use for that first step, superlearning is a classically recommended one, although Mark will talk at the end of the day today about additional advances in machine learning, and we heard some from highly adaptive lasso from Helene yesterday as well. So that said, superlearning is really based on this idea of setting up a competition of algorithms, including data adaptive approaches, but also potentially parametric regression models based on expert consultation, considering convex combinations of these algorithms, and choosing the convex combination that performs best, where performance is judged based on v-fold cross-validation, so internal data splits, where we partition our data into folds, fit each algorithm on a training set, and evaluate performance on the validation set and average across the validation sets. With, as Helene mentioned yesterday, the opportunity to choose a loss function that matches our problem well. So with that under our belts, then we have an initial estimate of our outcome regression. We then are going to target it. And so in this particular algorithm, we are targeting by basically on the logit scale using maximum likelihood to fit an intercept. So we do a logistic regression of the observed outcome on the intercept using our initial estimator as an offset. So importantly, what are we doing here? We're taking that initial estimator and we're moving it, and we're going to fit that epsilon. We're going to fit that shift, if you will, using maximum likelihood. The final piece of this is, though, that we're not going to give every observation equal weight when we do that fitting. So instead, what we do is we give persons weights inversely proportional to their treatment mechanism. So again, just the same idea as IPTW, where observations that are unusual are going to get upweighted when we do that fitting. As we also heard about yesterday, really thinking about where this comes from, this model is constructed to ensure that by fitting epsilon in this way, we're going to end up with an updated estimate that solves the efficient influence curve estimating equation, which is something we want, sort of a necessary condition for having an efficient estimator. So then we get our targeted estimate of the outcome regression, and we plug it in just as we would with the GComp estimator to get our final estimate. So some properties of this estimator, and all of this, I promise we'll get to multiple interventions. All of this is going to carry over very straightforwardly to multiple time point interventions. So some properties of this estimator, we mentioned double robustness, so consistency if either the outcome regression or propensity score are estimated consistently. Efficiency, so achieving the lowest asymptotic variance among regular asymptotically linear estimators if both the outcome regression and the propensity score are estimated consistently at reasonable rates. The ability to incorporate machine learning while still maintaining valid statistical inference, although of course that's not a free lunch, so we still really need our estimators of these quantities, the machine learning estimators of these quantities, to be as good as they can possibly be, and we'll hear about progress on that in the second talk today. And then finally, it has the nice quality of being a substitution estimator. This is helpful. It can give us improved robustness to sparse data. So there are a number of software packages available that implement this estimator for both the single time point and the longitudinal setting. So I'm just going to give some examples of one here because it's the one that's most familiar to me. This is the LTMLE package in R, and there's a vignette that illustrates all of these examples with additional text. So just to give a flavor of what it looks like to call this, it's a one-line function where you identify, in addition to your data, your A nodes, where again, we're using A to reflect the intervention, your Y nodes, here Y is our outcome, and then the level of A you're interested in. So this is how you would do just the most basic call to this function to get an estimate of the expectation of the counterfactual outcome under no treatment. The package can also do IPTW and can also do G computation using the implementations that I just described before. And then finally, you can also contrast your expected counterfactual outcomes either on a relative scale or on an additive scale. And then finally, I should note that the estimated standard errors for all of these are based on estimates of the influence curve. All right, so that brings us to longitudinal interventions. So I think with that, that under our belt, we're now in a good shape to talk about how could we extend all of these concepts to handle these more complex questions. So going back then to our motivating causal question, we wanted to ask about the effect of enrollment into this triage program, this low-risk express care program on patient retention and mortality. So we started off by saying you could ask about the effect of a single time point treatment. So how was retention different if everyone, we have a population of patients who are all eligible, how would their retention and mortality differ at 18 months if they'd all enrolled immediately versus none had enrolled immediately? So this is nice. It's the effect of a decision or action at a single time point. It's easy to get our heads around. And the analog really in the RCT setting is it's the initial randomized assignment to a treatment. You control that very initial assignment, but you don't control anything that happens after, typically. So all well and good, but maybe this isn't the question that we're most interested in. So if we think about that counterfactual outcome under don't enroll immediately, it again really doesn't control anything that happens after that initial decision. It says, okay, don't enroll immediately, but then after that, really that process is left random in our ideal experiment. This says this counterfactual outcome reflects what happens to people if we prevent them from enrolling that first time point, but they still could have gone on to enroll at the second time point or the third time point. So that doesn't make it ill-defined, it doesn't make it uninterpretable, but what it might make it is not the most interesting question to ask. And this is where, again, the core first concept of the roadmap is make sure that you've really outlined your question and you understand exactly what your ideal experiment is, what your ideal protocol is, essentially, what you would do, ethics and feasibility aside, just to learn the answer to your question. So to build on that then, what if we want to know about the effect of enrolling immediately? Okay, that's fine, versus never enrolling. So now we want an intervention that actually involves multiple decisions, multiple interventions. Don't enroll in the program at the first time point, or the second time point, or the third time point, etc. So in terms of our observed data, we actually need to recognize that our observed data in this case are also more complex. So we'll keep our discrete time scale corresponding to clinic visit interval and consider then 7 discrete time points here, t equals 0 to 6. As before, we have baseline covariates that are measured at time of eligibility. So we know patients' age, sex, CD4 count, whether they're urban or rural. But now we also really want our observed data to reflect what we actually measured. And in clinical cohort data, as in many, many settings, we really also have these very important time varying characteristics of patients. So in this case, we're tracking their CD4 count over time, any changes in their antiretroviral regimen, self-reported adherence, whether they develop tuberculosis, whether they become pregnant. And all of these variables can really have important effects on both the subsequent retention and mortality, but also on decisions to enroll in the program. Our outcome now, we're going to also really now encode the fact that this is really a time to event outcome. Again, it's as we've done it here on a discrete scale, but we can now define our YT as just an indicator that you're either lost to care or have died by time point T. And then similarly, we need to respect that our intervention is a time-varying intervention. So first, I'll just note I switched from A to E here, and I'll make that clear in a second. But here we're going to use ET to denote an indicator that you've enrolled in the low-risk express care program by time T. So everybody starts out of it, and then this ET jumps to 1 when a patient enrolls, and then remains there. The reason I say it remains there is because we really just define this as an indicator that you've enrolled by time T, not that you remain enrolled at time T, although that's an extension that could also be straightforwardly incorporated. And then finally, we've got this additional complication. So now we also have a right censoring process. So right censoring here is not due to drop out of care, because that's actually our outcome in this particular example, but we did have right censoring due to 2 things here. One was that a patient could have been transferred to a clinic where this just simply wasn't available. And then the second was database closure. Database closed at a given calendar time, but baseline eligibility was across a range of calendar times. So we'll just introduce a bit of notation then that will help in the extension of our estimators to this longitudinal setting. So first, we're going to separate out our observed random variables into 2 buckets. One are the variables that we don't, in our ideal experiment, in defining our question, we don't want to mess with how they're generated. And so these are the so-called non-intervention nodes. We're not going to change how the value of these variables is assigned based on the past when we think about our observed experiment. So here, these nodes consist of our outcome process and also our time-varying covariate process. And the typical notation that we use in longitudinal data is an overbar to refer to the history of a variable. So L bar T here is the history of this, these non-intervention variables, or the vector of non-intervention variables over time up till time T. And then the other bucket are the so-called intervention nodes. So these are the variables that when we think about defining our ideal experiment that would really let us address our question of interest, these are the variables where we do want to intervene to change how they're assigned a value in this ideal experiment. So this is where the A comes back and why I switched to using an E for that enrollment before. So typically we refer to these intervention nodes as AT, and they can include both things like the exposure process. So in this case, we're interested in intervening to set when somebody enrolls in this program. That's the ET, but they can also involve the censoring process. I think this is an extremely powerful way of thinking about censoring and actually missing data in general, is really through this causal roadmap that we could think about. Our ideal experiment often involves preventing missingness in some form, preventing right censoring, ensuring everybody's measured. So we can use the same causal framework to think about defining counterfactuals, where we not only intervene to assign treatment the way that we're interested in, we also intervene to prevent right censoring or to prevent missingness. And this is, again, like most of the good insights from the causal roadmap, that's not a novel way of thinking about censoring, but what linking it to the roadmap does is it allows us to do things like, for example, use causal graphs to assess what variables we would need to adjust for in order to, for example, control for informative censoring, and then use this process of identification to translate that into an estimand or a statistical parameter that we may not have landed on otherwise. So in this example then, our intervention nodes are the exposure nodes and the right censoring nodes. So now here's our more realistic observed data structure, where we have our 15,000 copies corresponding to a vector of non-intervention nodes over time, where those include the outcome process, and a vector of intervention nodes over time, where those include the exposure and right censoring process. So again, we can factorize the distribution of our observed data. Just like we did before, we can factorize it into components that involve the treatment mechanism or the conditional distribution of treatment given the past, and components that involve the conditional distributions or densities of the covariates given the past. And again, we're going to be working in large statistical models that place restrictions, if any, only on the treatment mechanism. So we need a target causal parameter then. So what do these parameters look like when we now get into the case of multiple interventions? So we're still going to focus, just for illustration, on, as an outcome, this indicator of being lost to care or died by 18 months. And so what we'd now like to ask is, how would your counterfactual probability of having been lost to care or died by 18 months have differed if you first had never enrolled in this program? So your E-bar vector, your exposure vector is set to 0. That decision at every time point is 0, and censoring was prevented. So that's this first expectation of the counterfactual outcome here. Just to keep our notation reasonable, we'll just refer to that as the expectation of the counterfactual outcome at time 6 under this intervention to always set enrollment to 0. So just abbreviating that as a 0 bar. And then we can do a similar thing for enroll immediately and prevent censoring. And so now we can talk about a new version of an average treatment effect, where we're still contrasting expected counterfactual outcomes on an absolute scale. But now these counterfactual outcomes are really indexed by interventions at multiple time points. And you should be able to see here, so I've done one extension to include interventions at multiple time points and prevent censoring. You can also start to get a flavor of how flexible this framework is. So when you define these ideal interventions, really you just need to say, what are the ways in which I want to set exposure, missingness, et cetera, at every time point in order to answer my question, in order to define my ideal experiment. And if you can say what it is you want to intervene on and how you want to intervene, then you can define these counterfactual outcomes and then contrast them however you want in order to quantify your effect of these different longitudinal regimes. That brings us then to identification. So in terms of identification, the problem also gets harder in this case, and we saw a preview of that on earlier days. So the core of the problem here, I've just boiled it down to kind of the basic causal graph. Clearly, the observed data structure that we just discussed would be a more complex graph involving more time points, as well as a right censoring process. But I think this graph serves to make the point, which is that a really core difference when we go after these longitudinal effects is that we're interested in the effects of multiple treatment decisions over time. So in this case, for illustration, the effect of enrollment at time 0 on the final outcome and enrollment at time 1 on the final outcome. Importantly, though, in these longitudinal settings, often we have cases where part of the effect of that early enrollment decision on that final outcome is mediated by these time-varying intermediate variables. So for example, whether or not I enroll at the first time point might affect my health at the second time point. And my health, and that can be also important in terms of determining my final survival. So we have a causal pathway here. But importantly, my health at this post-baseline time point can also act as a confounder, because it can also determine whether or not I enroll at the next time point. So patients, for example, who don't enroll and become sicker may be much less likely to enroll. And so this is this variable is sort of classically referred to as a time-dependent confounder. this exact same structure, as we've heard about a little bit, can come up with right censoring as well, where we're in a setting where earlier treatments affect intermediate covariates that then go on to affect both whether a patient drops out of the study as well as their outcome. And so we really need to control for these time varying covariates to adjust for informative censoring, but they're often affected by earlier treatment decisions. So this exact same sort of causal graph and then solutions can also apply to that case. And indeed do in this particular example where we have both right censoring and enrollment. So we've got this conundrum. We introduced before this idea where if we can look at our causal graph and find some set of covariates that lets us block all these backdoor paths with arrows into our exposure variables, if we can somehow find all those and condition on those, adjust for them in some way, we can remove the sources of association between our exposure and our outcome that are only coming from these shared common causes, these confounding pathways. The problem is in this longitudinal setting that there is no such one set of variables. Instead, we have this guy who's really, we need to condition on this variable in order to block the confounding here, this source of association between enrollment and the outcome. But we can't approach this in the usual way because this is really affected by earlier exposure. And this was really, this is a long-standing problem across many fields where our work by Robin in the early 80s really opened a path forward to address this. So the core insight here is that instead of tackling this all at once, we basically break it into parts and tackle it in turn. And that leads us to the sequential randomization assumption. So sequential randomization really just does the same thing we did in the single time point case, but applies it to this multiple time point. And we can also similarly apply an extension of the graphical criteria to this multiple time case. So what we do essentially is for each of these intervention nodes in turn, we say, okay, first for baseline, is there some subset of the observed paths that I can use to block all of the paths between this exposure and the outcome that are not part of the effect I'm interested in? And so in this case, yes, I can condition on W0 and that'll block this source of association. Then I move to the next time point. I say, I'm not trying to do it all at once, I do it in series. So at this next time point, is there now some subset of the observed paths that will block all of the association between this time point and the outcome? That's not what I'm interested in. And indeed here now we can use this whole past. We also have an extension of the positivity assumption to this case. And so in terms of positivity, it's really the exact same idea. It's just that we now need this to hold for every time point that we're intervening on. So for every time point we're intervening on, we need some positive probability of following the regime of interest, given you followed the regime of interest so far. So if we're looking at not enroll, given you haven't enrolled so far, irrespective of your covariate history so far, you need some positive probability of not enrolling. And we need to hold that to hold for all of our regimes of interest. So in this case, we need it to hold for enroll immediately and don't be censored, and never enroll and don't be censored. So again, this is a point where it's really important to give careful thought. So in this longitudinal case, for example, even though we started off with a target population where everybody was eligible for immediate enrollment, in this case, if we might have, as we move forward over time, some patients who lose eligibility, who become too sick to enroll. So that would mean that such patients would have no probability of enrolling. And so we wouldn't be able to look at regimes like enroll 2 time points after eligibility, because we'd be opening up this door to saying, yes, but patients who lose eligibility during those first 2 time points now have 0 probability of enrolling at that 3rd time point, for example. So that would be a violation of this positivity assumption. In our case, though, we've defined these 2 regimes kind of deliberately to avoid that. So the first one says enroll immediately. And that, by definition, everyone is eligible to enroll immediately at the start of this follow-up. And the other one says never enroll. And so for never enroll, it's not a problem if you lose eligibility. You still have a positive probability, in fact, a deterministically positive probability of enrolling of not enrolling at future time points. So under this sequential randomization and positivity assumption, we can look at the generalization of that single time point G computation formula. And this is the so-called longitudinal G computation formula. Really, the idea is exactly the same. So we've got here our expectation of our outcome, given that you followed the regime of interest, so you either never enrolled or always enrolled immediately, and given your covariates. But then the difference is that we integrate with respect to the post-intervention distribution of the covariates. So in other words, at this step, we're really recapturing what the values of those covariates would have been under the regime of interest. So we don't lose that aspect of the effect that's mediated by those intermediate covariates. So with that estimand in hand, we can think about these exact same estimators. So I'll first look at parametric G computation and IPTW, and then extend it forward. So the parametric G computation estimator, just like in the single time point case, is based on estimating the non-intervention factors of these observed data distributions. And essentially you estimate them and then you simulate from them, which is nice and intuitive, but is susceptible to bias due to model misspecification. In terms of the inverse probability of treatment weighted estimator, again, it's really exactly analogous. The two differences are really just that now we have our treatment mechanism that consists of both probability of enrollment at each time point and probability of remaining uncensored each time point. So we need to estimate both of those. And then of course, it's now becomes a product over time because there are decisions being made at multiple time points. So just like in the single time point case, we could estimate this treatment mechanism. So our probability of enrollment given the past, our probability of censoring given the past, using parametric regression models like classically logistic regressions. But once again, we run into this issue of bias due to model misspecification. And while we can also employ data adaptive or super learning methods, as we noted in the single time point case, it raises challenges for inference. So finally, then, that brings us to the extension of, one possible extension of TMLE to the longitudinal case. And before I introduce it, I just want to first introduce a different way of writing the longitudinal G computation estimand. So in terms of this estimand, this is we can take that original G computation formula and we can re-express it in terms of iterated conditional expectations. So we've just rearranged that same guy from before, haven't changed anything. So why is it worth doing this? Basically, the idea is that by re-expressing the estimand this way, it opens the door, or it immediately suggests an alternative approach for both parametric G computation, but also double robust estimators. So really what we've done is we've changed our prior estimand, which was a function of this regression object and this series of conditional distributions and densities. Instead, we've just re-expressed it as a form of nested regression objects. And so that's nice because what we have here are nested regression objects. We have on the inside that same expectation of the final outcome given you follow the regime of interest in the past. And then we take that object, take its expectation given a time reduced past, and iterate outwards until, or not iterate outwards till we get to the outermost expectation. So why would we want to do this? It really gives us potentially an easier set of factors to estimate well. They can be lower dimensional and have been, basically we've turned the problem into a series of regressions. So we can implement an estimator in that way based on just estimating these series of nested outcome regressions. So first we estimate the inner one, then we generate predicted values evaluating at the treatment regime of interest. Then we use those predicted values from the first step as the new outcome in the next step, regress on now the time reduced past, generate predicted values again, and repeat until we get to that final time point and take the empirical mean. So finally then, that brings us to the longitudinal TMLE estimator. And I know we are at the top of the hour. I think we actually have a little bit of extra time in the second hour from the schedule Thais showed. So I'm going to wrap up this longitudinal TMLE and simulations. Then I think we'll take a break and do questions after break before going to Mark. So finally then, that brings us to the longitudinal TMLE estimator. So again, these properties that it has really carry over from or are analogous to the properties in the single time point case. It has this nice double robustness property. It's efficient in this large statistical model. It can incorporate machine learning while retaining inference, and it's a substitution estimator. So what does it look like for, or at least what does one particular TMLE algorithm look like for this expectation of the counterfactual outcome under multiple time points? Here we can just bring together that basic targeting approach we learned in point treatment with this iterated conditional expectation approach for the regressions that we just saw as a way of re-expressing our GComp estimand. So basically the idea is that we use an estimator that's exactly analogous to our iterated conditional expectation G-computation estimator with just two key differences. The first is that when we think about estimating each of those nested outcome regressions, we can and should bring in machine learning. So for each of those nested outcome regressions, we want to estimate them as well as possible, and we can put machine learning to work for us. The second is that at each step, before we move on to fitting the next conditional expectation, we just do an update step, a targeting step, where we update that initial fit. And the approach to targeting is exactly analogous to that single time point targeted maximum likelihood estimator. It uses an inverse propensity score weight and confers the same potential advantages as in the single time point case. So a quick feeling for what that looks like. We start by estimating the innermost conditional expectation using superlearning, then update our initial estimate just as for the single time point, using maximum likelihood to fit an intercept-only logistic regression with our initial fit as an offset, and then these inverse weights, where now the inverse weights incorporate the whole treatment mechanism over time. And again, this treatment mechanism can be estimated using superlearning. And then we repeat for that next nested regression, et cetera, until we get down to the last time point and take the empirical mean. So this is also implemented in the LTMLE package, where we have some A nodes or intervention nodes, C nodes to indicate right censoring. L nodes in the package syntax are used for time-varying covariates, and Y nodes for outcomes. And so this is just to show you can use that same call now for longitudinal interventions. So here we're saying now we want to intervene at 2 time points, A1 and A2. And the intervention we want to do is to set them both to 0. We can also integrate right censoring. So censoring nodes again are called C nodes. So we just tell the package, these are the treatment nodes, these are the censoring nodes, these are the time-varying covariates, these are the outcomes, and then this is the intervention that I want to do on the A nodes. I want to set it to 1 and then to 0. And then finally, the package also calls superlearner, and then you can you can either use a default library or, as is recommended, choose your own library to flexibly estimate both your outcome regressions and your propensity score. And just as in the single time point case, we can output effect estimates at the absolute or relative scale. So just to conclude then, I'll show some result of a simulation and then result of the data analysis. So this plot is plotting MSE on the y-axis and time on the x-axis. And the key thing about time here is as we move forward in time, we estimate the expectation of the outcome at later time points. The potential for positivity problems increases because we're taking a product of the treatment probabilities over more time points. So I think the key take-home point here is, so here's our GComp estimator with correctly specified parametric models. So as we expect, it does well throughout. The real point though is that we in practice, not simulations, never really know enough to do these correctly specified parametric models. And so we lose our basis for inference. Here, for example, is the IPTW estimator showing how MSE increases as positivity problems increase. Again, using a correctly specified parametric model. And then finally, here's the TMLE estimator described here, which does pay some price for working in this larger statistical model, but really performs quite well. And then finally, what did the data analysis look like? So here, of course, it's a real example, so we don't know the truth. But in this example, we would expect that in the unadjusted estimator, patients that never enroll are generally the sicker patients. And so if we adjust effectively for that at both baseline and over time, it should shift this bottom blue survival curve up. And indeed, that's what we see when we implement this TMLE estimator. So it's at least consistent with better control for confounding. It's true that patients who become sick are less likely to enroll as we expect. So just to conclude, with many thanks, we have these longitudinal targeted maximum likelihood options, integrating machine learning to go after both expected counterfactual outcomes of these longitudinal regimes, but also a whole range of more complex parameters like dynamic regimes and marginal structural models. That this offers the potential for real benefits, but as we'll hear from Mark coming up next, care really is needed. So there are a number of things that can go wrong with this approach, just as with all statistical estimation approaches. A few key ones are making sure that there's sufficient support and getting into these settings for marginal support of specific treatment regimes. The risk of overfitting your initial outcome regressions and what we can do about that. And then finally, working to ensure convergence rates of your machine learning based estimators. And so that is what Mark will be talking about coming up next. So I will conclude there. Let's take 5 minutes and then come back, and if that's all right, Thais, and do a Q&A after a break. I feel people might need a bio break, so would that be all right? All right, you're muted, so. All right, let's take a 5-minute break and we'll come back and do questions before moving to Mark. Thanks.
Perfect, thank you, Maya. 5-minute power break.
Hey, Maya. Can you hear me?
Here we go. Yeah, I made that long because we had extra time because Kais is not concluding, so.
Okay.
Hello, can you hear me?
Let me see, am I muted? No, can you hear me?
No, I hear you. Do you not hear me?
Yeah, I hear you now, yeah.
Okay.
Can you see my slides? Or let me see if
Yeah, I see your slides, yeah.
Okay, so I need to, wait a minute, I guess window, full screen. Let me just make sure. Does this look okay?
Yeah.
Okay, good.
So I know I did overtime, but it's because our schedule had shuffled. So I thought I would leave half hour for you.
So how much time do I have, did you say?
You should have half an hour. If we come back at a little before 8:15 and do say questions to 8:20, then you have still half an hour with plenty of time for questions.
Okay, now that's more than enough. So.
Yeah. I just went slow because we had a shuffle in schedule, so I was going slow.
Oh, so normally Thijs would have talked more, or would have...
No, we had it was sort of a last minute thing. Thijs was perfect, but yeah. Just so you know, I wasn't completely ignoring the time.
Hey, it was great. Very clear.
Yeah, so you should take your time. You for sure got half an hour.
Okay.
No questions though, oh dear.
So, welcome back, everybody. And now I can get to say thank you, Maya, for a nice presentation. I have a few questions I got on email, but I would also like to open the floor in general. If there are other questions, you can mark it in the Q&A. But the first question I had, and I guess it's a general question, but one could refer to your slide, Maya, on sort of the mean square error as you move across time. And it's an lived experience where a binary outcome was analyzed with the TMLE. So I guess we can think of it just as the time one part. That must be, if we only look at that part. It was analyzed with TMLE, number of covariates, and then the IPTW was performed as well as a sensitivity. But then it consistently showed that the IPTW was more precise in the sense of narrower confidence intervals for the parameter of interest. Is that something you say, of course, or too bad, or are we to expect stuff like that?
Well, maybe the first, I'll have a pass, and then maybe Mark can have a pass as well. I mean, I think my first question is, this was a simulation or real data?
Real data, real data.
So one thing that can happen with IPTW is if you get to areas where so positivity is one potential explanation. So if you have a setting where there is, for example, one sick person, in my example, one very sick person who enrolled in the program, that one very sick person would have a small predicted probability and a big weight, and IPTW should get big. But if in your finite sample, you ended up with no such person, right? So you've got a positivity problem, a practical positivity problem, but you've got nobody there to be upweighted, then you can really have a problem in terms of bias. And that's not going to show up in terms of increased variance. So I think that's one thing that can go awry with IPTW. It looks like this very nicely behaved low variance estimator, except that it's biased because of positivity. So that can be an issue. I think the other things, though, I would want to know are how are the weights being estimated, and how are the nuisance parameters and treatment mechanism being estimated for TMLE as well? Because you can also, if you're essentially working in a small statistical model because you use a low dimensional parametric regression for your weight, that can look lower variance because you've essentially forced your statistical model to be smaller by working with this kind of like simple weight model. And if you kind of make it unfair by having TMLE work in the much larger statistical model where you're using the full power of machine learning, I would say that would be another way in which you might be comparing apples and oranges. But that's a couple things that jump to mind. I don't know, Mark, do you want to comment on this question as well?
Yeah, so generally speaking, I would recommend to do a little simulation imitating your data analysis, right? You can fit your treatment mechanism in your regression and then simulate and see the behavior of these estimators, because then exactly the kind of issues Maya was pointing at might pop up, such as indeed that, sometimes there is positivity violations, but they don't show up in the data because the weights are, the unlikely events just don't happen, even though they do cause bias, they are not showing up as large weights. Again, how do you implement TMLE? I presume this is using the standard TMLE package.
Yeah, it was pretty.
Yeah, so then, there are different ways of implementing TMLE, and that one puts it in the weight. That's actually pretty robust, so that should not explain why it would be more variable. The other thing is gain of efficiency of TMLE comes from doing a good job on the outcome regression. So that's something, I don't know how you did it. How you fitted the outcome regression. Did you do a good job, right? But if there's, for example, essentially gain in efficiency has a lot to do with gain in R square, right? How much are the covariates helping to improve your predictive power for the outcome? In particular, in a randomized trial, that's precisely where the gain in efficiency comes from.
And if they don't, there will be no gain.
What's that?
And if they don't predict very much, there will be no gain, perhaps
exactly.
even a
Like
price.
exactly right. For example, in a rare outcome situation, there is no gain in efficiency, right? So it's purely bias you worry about. And that's where TMLE can still be helpful by having this double robustness and therefore have more like quadratic bias instead of just bias only due to G. But you're not going to get a gain in efficiency, even in like in a randomized trial. So absolutely right.
Okay, thank you.
But
I guess it was also okay to
much more about the situation you're in. But
no, but I guess also the simulation advice is generally good. That you should remember that. Yeah. There's a question in the Q&A. I'm just going to read it out loud. Hi Maja, thanks for the great talk. I'm wondering, is the framework of LTMLE and sequential regressions also applicable for randomization on community group levels? And I guess you can broaden the question a little bit to all these kind of, there is something nested going on, or that these kind of issues. What do you think? How do we address these real life challenges?
Great question. So I guess briefly, yes. And one thing I'll note about the LTMLE package as well, just because I happen to highlight that one, is it is able to handle hierarchical data as well, in terms of providing influence curve-based variance estimates, where you provide the independent ID variable. So, for example, the community or the cluster, for example, and then that information is accounted for in the influence curve-based variance estimate. So so the short answer is yes, and that is an option in the LTMLE package. The longer answer is that I think when we get to these cluster randomized or more general hierarchical data settings, in addition to them being longitudinal settings, all sorts of additional complications and ways forward can arise. And I think this is an area of really exciting active research. And so there's a number of papers that we can just put up on the website where people are working through this problem. To note just one example of work done by a former PhD student that I think is particularly sort of exciting and relevant to this question is this idea that in a pair-matched randomized trial, for example, as we've done, you really are working with a very small number of independent units. You want to get something out of your adjustment, but you're really limited in how much you can adjust. And so this idea of taking this, using TMLE and using data adaptive approaches to choose the adjustment variable, especially in a cluster RCT, that gives you the best precision, is I think a really important one. And she's done really nice work showing that you can use essentially a cross-validated variance estimate to compare different adjustment variables and select those in a rigorous way to get more power out of your cluster RCT. And so I think a lot of potential for that sort of work as we think about applying these methods to especially the smaller cluster RCTs, or the RCTs where there are fewer independent clusters.
Thank you. I think that's, in general, it's going to be a bit of a challenge when we are suggesting something quite new, is that all these additional tools we have developed for this or that particular solution in a problem in a regression, are they still applicable? But that's as you say, it's going to be a future research. I will have to cut the questions now.